Good morning everyone. Today we are going to talk about deviated nasal septum, that is DNS, and it is the most important cause of nasal obstruction. And talking about its etiology, it is due to the trauma, developmental error, racial factors and hereditary factors. And for trauma, it is due to the front blow, lateral blow displacement, and it is most commonly seen in the Caucasians. Now let's talk about the anatomy of the nasal septum. Nasal septum consists of three parts, that is columellar septum, membranous septum and septum proper. And talking about the columellar septum, it is formed of columella containing the medial crura of alar cartilages united together by fibrous tissue and covered on either side by skin. And talking about the membranous septum, it consists of a double layer of skin with no bony or cartilaginous support. And for the septum proper, it consists of osteocartilaginous framework and it is covered with nasal mucous membrane. And its principal constituents are the perpendicular plate of ethmoid, the vomer, and a large septal cartilage also known as quadrilateral cartilage. And other bones which makes minor contributions at the periphery are crest of nasal bone, that is crest of nasal bone, nasal spine of frontal bone, rostrum of sphenoid, crest of maxilla, crest of palatine bone and anterior nasal spine of maxilla. So this was the overall anatomy of the nasal septum. Now moving on to the types of deviated nasal septum. The types of deviated nasal septum are anterior dislocation, C-shaped deflection, S-shaped deflection, nasal spur impinging on turbinates, and thickening of nasal septum. Now talking about the types, there is anterior or caudal dislocation, and in this dislocation, the nasal septum dislocates into one of the nasal chambers, and in deviation, that is C-shaped deformity, it is deviated in a simple curve to one side that may lead to the compensatory hypertrophy of turbinates. And in S-shaped deformity, there is bilateral nasal obstruction, and in spurs, there is self-like projections and it is found at the junction of bone and cartilage. It may press the lateral walls that may lead to the headache, and it is also predisposed to repeated epistaxis. And talking about the septal thickening, it is due to the organized hematoma or overriding of septal fragments. So this is anterior dislocation where the septum is dislocated into one of the nasal chambers. The septum is dislocated in one of the nasal chambers. And in C-shaped deflection, there is deviation in a simple curve to one side which leads to the compensatory hypertrophy of these turbinates. And talking about the S-shaped deformity, there is bilateral nasal obstruction, and in nasal spur impinging on turbinates, the nasal spurs are self-like projections. They are self-like projections and they are found at the junction of bone and cartilage, and they may press in the lateral walls that may lead to the headache. And talking about the septal thickening, it is due to the organized hematoma or overriding of the septal fragments. So these are the types of deviated nasal septum. Now moving on to the clinical features, there will be nasal obstruction in the patient that may be unilateral or bilateral. The patient may complain of headache, sinusitis, and there could be presence of epistaxis as well, and there will be anosmia, and there will be external deformity as well, and middle ear infections can also be seen. Now moving on to the treatment. The treatment is required only when the deviated nasal septum produces mechanical nasal obstruction or any symptoms, and it can be treated by submucous resections and septoplasty. Septoplasty has now almost replaced the SMR operations, and let's talk about the differences in them. Now talking about the submucous resection, it is a radical surgery, whereas septoplasty is a conservative approach, and submucous resection is done in adults under general anesthesia, that is more than 17 years, and septoplasty can be done after 4 years. And in submucous resection, Killian's incision is given, whereas in septoplasty, Freir's incision can also be given. In submucous resection, It cannot correct anterior deviated nasal septum, whereas septoplasty can correct it. And in submucous resections, there is bilateral mucoperichondrium elevation, whereas in septoplasty, mucoperichondrium is elevated in only one side. And in SMR operation, there is radical removal of cartilage, whereas in septoplasty, there is removal of only inferior strip. And rhinoplasty incision cannot be combined with SMR, whereas it can be combined with septoplasty. And talking about the revision surgery, in SMR operation it is very much difficult, whereas in septoplasty it is relatively easy. And in SMR, cartilage graft can be harvested, whereas in septoplasty it cannot be harvested. And the complications is very much common in SMR, whereas complications are very rare in septoplasty. So these are the few differences in SMR and septoplasty. Now talking about the complications of septal surgery, there could be hemorrhage, septal hematoma, septal abscess, septal perforation, suprative deformity, saddle nose, columeral retraction, persistent deviation, nasal synechia, and CSF rhinorrhea, infection, toxic shock syndrome. Thank you. Now let's talk about septal hematoma. Septal hematoma is the collection of the blood under the perichondrium or periosteum of the nasal septum, and it is due to trauma, surgery, or any bleeding disorders. Now talking about the clinical features, there will be bilateral nasal obstruction, there will be frontal headache, and there will be sense of pressure over the nasal bridge. On examination, smooth rounded swelling of septum can be seen, and on palpation, the mass can be felt soft and fluctuant, and there is absence of raised temperature, erythema, and swelling of skin over nose. And moving on to the treatment of septal hematoma, for the small hematomas, it is aspirated with wide bore sterile needle, whereas for large hematomas, we should do incision and drainage, and nasal packing can also be done for the prevention of reoccurrences, and systemic antibiotics should be given to prevent septal abscess formation. And now talking about the complications of septal hematoma, the septal hematoma can get organized into a fibrous tissue and it can lead to the septal thickening. And there could be secondary infection to the septal hematoma as well that may lead to the septal abscess formation with necrosis of cartilage, and there could be depression of nasal dorsum as well. So this is septal hematoma. We can see the collection of the blood. We can see the collection of the blood under perichondrium or periosteum of the nasal septum. Now moving on to the septal abscess. Mostly it results from the secondary infection of the hematoma, and occasionally it follows furuncle of nose and lips, and it may also follow the acute infections such as typhoid and measles. Now talking about the clinical features, there is severe bilateral nasal obstructions with pain and tenderness over the nasal bridge, and the patient may also complain of fever with chills and frontal headache, and the skin over the nose may be red and swollen. And internal examination of the nose reveals smooth bilateral swelling of the nasal septum, and fluctuations can be elicited in that swelling, and the septal mucosa is very much congested, and submandibular lymph nodes can be enlarged and tender. Now moving on to the treatment, the abscess should be drained as early as possible. And the incision is made in the most dependent part of the abscess, and a piece of septal mucosa is excised, and pus and necrosed tissue of cartilages are removed by suction, and the incision should be reopened for 2 to 3 days to drain any pus or to remove any necrosed piece of cartilages. And systemic antibiotics are started as soon as diagnosis has been made, and it is continued at least for the 10 days, and culture and sensitivity of pus guides the choice of antibiotic. Now moving on to the complications, there could be necrosis of the septal cartilages, which often results in the depression of the cartilaginous dorsum in the supratip area and may require augmentation rhinoplasty 2 to 3 months later. And there could be necrosis of septal flaps that may lead to the septal perforations. And it can also lead to the meningitis and cavernous sinus thrombosis. Now let's talk about the perforation of nasal septum. The etiology of perforation of nasal septum are traumatic perforations, pathological perforations, drugs and chemicals, and idiopathic. Now let's talk about the traumatic perforations. Trauma is the most common cause, and injury to mucosal flaps during SMR, repeated cauterizations of septum with chemicals like phenol, trichloroacetic acid, silver nitrate, and galvanocautery for epistaxis, and habitual nose picking are the common forms of trauma. And occasionally, septum is deliberately perforated to put ornaments as well. Now talking about the pathological perforations, it could be due to septal abscess, nasal myiasis, rhinoliths, foreign body, chronic granulomatous conditions like SLE, TB, leprosy and syphilis, and Wegener granulomatous diseases. Now talking about the drug and chemicals, steroid sprays, cocaine addicts, and arsenic exposure may lead to the perforation of nasal septum. And under idiopathic, there is no history of trauma and the patient is also too unaware about the perforation. Moving on to the clinical features, if there is presence of small anterior perforations, it may lead to the whistling sound during inspiration and expirations, and if there is presence of large perforations, then it may develop crust, and this crust can obstruct the nose, and it can also lead to the severe epistaxis when it is removed. First of all, we have to find the cause, and we should do biopsy from granulations and edges of perforations. And if there is presence of small perforations, then it could be surgically closed by plastic flaps. And if there is presence of large perforations, then first of all we have to make it crust free by alkaline nasal douches. And application of the bland ointment should also be done. And sometimes a thin elastic button can be worn to get relief from the symptoms. Thank you.